Okay, so now I'd like to welcome our final speaker. Dr. Deborah Zarin is a true expert on clinical trials. Her own research focuses on the quality of trial reporting, as well as issues in trial design and analysis, and she's the author of over 80 peer-reviewed journal articles. Dr. Zarin used her clinical trial expertise at both the Agency for Healthcare Research and Quality and at the American Psychiatric Association, where she conducted systematic research reviews in support of evidence-based clinical and policy recommendations. She oversees ClinicalTrials.gov, the world's largest clinical trial registry, and she's in the midst of making major improvements to the site, which of course features SWOG and NCTN trials, and she'll give us an update on that work. Welcome.
Thank you. It's great to be here. Let's see if I can figure this out. I assume I do this. I'm just going to give a brief update on ClinicalTrials.gov. I actually welcome you all to look at the site. If you haven't, hopefully you have, and I'll show you some features. But let me step back first and just remind everyone of why ClinicalTrials.gov exists. In the traditional system, like when I was in med school, and certainly as recently as 10, 15 years ago, the design and conduct of clinical trials was left to individual investigators or maybe groups of investigators. There was no specific training required, not much oversight of analytic methods. And individual investigators decided whether, when, and how to disseminate results of their trials. Institutions assumed, this is mostly academic institutions, assumed that fundamental academic incentives would ensure that this would always happen, but there was widespread appreciation or growing appreciation that not all results would be reported, and nobody seemed too worried about that. This is a famous example. I don't know how many of you have seen this, but this was from an article in JAMA about 15 years ago now. This is looking at celecoxib or Celebrex versus other NSAIDs, and it was trying to show, or the trial was designed to look at the probability of GI toxicity. So the vertical axis is the percentage of patients who had some ulcer-type complication. And the red line, celecoxib, looked significantly better. This was 6-month data than its comparators, and this was a lead article in JAMA, and Pfizer, I think, made a lot of money. The problem was when they published this, it turns out they had these data. These were the 12-month data. And you could see at 12 months there was no significant difference among the 3 different NSAIDs. But not only that, they had the 12-month data when they submitted and published the 6-month data. And it turns out they didn't tell the editor of JAMA, Kathy DeAngelis at the time, they didn't tell the peer reviewers, and their pre-specified primary outcome measure in their protocol was the 12-month data. Okay, so this was one of the, what I call the tipping point scandals that got the medical journal editors to require trial registration, because in this case, not only was JAMA scammed, but so were all of us, all the readers of the medical literature and doctors and others who made clinical decisions with or on behalf of their patients. So this was part of a cascade of events. Basically, ClinicalTrials.gov was developed in response to a 1997 FDA law, the FDA Modernization Act, which really focused on helping seniors, Medicare beneficiaries, find trials in which they might want to enroll. It was launched 3 years later, but that Committee on Medical Journal Editors in 2005 started to require trial registration after scandals like the Celebrex trial. And then in 2007, Congress, so that was about trial registration. That was saying, okay, we're going to require a public documentation of every trial before it starts. In 2007, Congress got into the act again because the FDAMA, the 97 law, had no enforcement. And so it was really not followed by pretty much anyone. In 2007, Congress, in the wake of many, many, many scandals and much more documentation of publication bias and other things, said, okay, we're going to make it a legal requirement for certain trials that involve drugs and devices to register in ClinicalTrials.gov and to report their summary results, aggregate results. So not only was Congress saying, okay, you have to register, it's a legal requirement, but you have to report your results. It took us 9 years, but we got really the implementing and the clarifying regulations promulgated this year, and the compliance date for those regs was last week, so I'll tell you a little more about that. So basically, ClinicalTrials.gov, you can think of it as addressing essentially 4 problems. One was a practical problem, helping people find trials, and that's what a lot of a lot of you probably spend a lot of time worrying about that. How can potential participants find your trial? And then 3 scientific problems. One is what I was just saying, not all trials are published. When they are published, not all outcome measures or adverse events are published, so that even if the trial's published, they might have cherry-picked some of the results. And then changes to protocols, like that 12-month to 6-month change, are not always acknowledged. And so these were the kinds of problems that ClinicalTrials.gov is designed to address. By the way, not all of the scandals came from industry. I just wanted to throw this in. Colleagues of mine and I looked at a cohort of NIH-funded studies. We had studies that completed, I think in 2012, we looked at up to 6 years, I guess they completed earlier than that. We looked at up to 6 years after trial completion, and fewer than 2/3 had ever been published. And this was a real wake-up call to NIH, and I got pilloried because the first response was to kill the messenger. And we were accused of having bad data, of not knowing what we were doing, though honestly this involved a numerator and a denominator, and I'm pretty good with fractions. Basically no one believed it, and every institute at NIH said, well, all of our grantees publish all their studies, and every academic medical center said it was wrong. It's since been confirmed multiple times. I'll tell you, the one institute that reacted in what I would call a productive way was Dr. Varmus called me to his office and said, this is absolutely horrible, what can we do to fix it? Which is why NCI was the first institute to have an actual policy about either publication or reporting results. So that was really nice to see. So again, because it's an it's a burden to have to report, and so I'm trying to front load this talk with all the good things that come from it. So we're talking about human subjects issues, both allowing people to find studies, assisting the ethical review boards. So, for example, one of the other scandals that led to all these policies was Paxil, where it's an SSRI antidepressant, where there was evidence that GSK, which was then SmithKline Beecham, had basically suppressed the data from many studies of Paxil in children, and the one study that they initially reported was reported in what's alleged to be a rather distorted way, so that there was evidence of harms and lack of efficacy that was being ignored. And they got sued by then Attorney General Eliot Spitzer of New York State. But imagine being on an IRB that's approving the 8th study of an SSRI in kids. And you're supposed to decide if the benefits outweigh the risks or if they're in balance for this study, and you have no idea about the other studies. So what exactly are you doing on that IRB? So this problem of not having complete literature affects research oversight as well as clinical decision-making. Clearly, there are research integrity issues like the Celebrex study. The practice of evidence-based medicine obviously depends on having access to all the data, not just a biased sample of the data. And then allocation of resources. We all want NIH and other research funders to actually use their precious dollars in a logical way. And you don't want to be funding a study without realizing that the study has already been done and completed and the answer is known, it's just nobody bothered to report it. Or you're about to fund a small study when it turns out a large study on the exact same topic is about to complete, et cetera. So clearly, the world needs this public resource. So here are the 3 policies that affect people in the US mainly in terms of trial reporting. The journal editor's policy, which requires trial registration. But then let's talk about FDAA, which is the 2007 law, and the NIH policy, which was recently promulgated to fill in the gaps. So FDAA requires both registration and summary results reporting at ClinicalTrials.gov, basically for phase 2 through 4 studies that involve a drug, biologic, or device. And then the NIH policy fills that in by saying if NIH has funded it, it covers your trial even if you don't involve a drug or device, and even if you're phase 1. So if you're doing an NIH-funded study, including from the cancer group, and it's a phase 1 or whatever, you now have to register and report results to ClinicalTrials.gov. There are pretty serious enforcement actions that are possible, including, it's not listed on here, and I can't remember if I put in the specific slide. I think I did. But if you are submitting a new grant to NIH for a clinical trial from an institution, let's say Stanford, and Stanford is found to not be fully compliant with FDAA, then you will no longer be eligible to get that funding. So it's an institution-level enforcement. So that should be a concern to everyone. So ClinicalTrials.gov, as I said, has the registration section, as we refer to it, which is done at the beginning and includes a summary of the protocol and recruitment information, other administrative data, and then this results section. The results section is sort of just the facts. It's designed for what I call readers of the medical literature. It's not designed for the lay public. And it's just a set of data tables. It's a minimum reporting set. They are legal requirements to have to show, for example, the summary results for all pre-specified primary and secondary outcome measures, all serious adverse events, all other frequent adverse events, et cetera. And we do a fair amount of quality assurance and curation of those data. We now have over 200,000 studies listed in ClinicalTrials.gov. We get about 600 new trials registered per week from over 16,000 data providers. We have about 26,000 sets of results. And the key thing is that in our studies, only about 50% of those have associated publications. So think about that. This is a unique source of results for thousands and thousands of studies. Okay, so there's a whole bunch of studies in there that have the summary results in ClinicalTrials.gov where you cannot find the results in the PubMed or in the literature. So this is more about noncompliance, and you can read more about it here if you want. So a lot of people say, why are you bothering with this if we publish? First of all, it's not up to us, it's now up to Congress. They decided this. But just to think about it, ClinicalTrials.gov, there's a requirement for a minimum data set, whereas journal articles frequently leave out pre-specified outcome measures. They certainly leave out certain adverse events, and they cherry pick some of the information. Journals provide background and discussion, including conclusions, and we don't. So the goal of ClinicalTrials.gov is to have just the facts, no spin. And studies have been done comparing the ClinicalTrials.gov entries with associated journal entries and have found, not surprisingly, that the ClinicalTrials.gov entries are more complete because they're, in fact, following structured legal requirements. Okay, so let me just show, we're working with journal editors and others to try to leverage the work people do to report their results to us. So for example, this is from a New England Journal article about a year ago, where in the meat of the article, in the results section, it says, okay, the protocol listed 27 secondary outcome measures. We have data for 19 of them here, but the others can be found right here at ClinicalTrials.gov, and it links right to the results database. So this is a nice use of that. And we've had other journal articles use it for, say, the serious adverse events, like saying, okay, all the serious adverse events are here, and they'll insert the link, but we're going to discuss in particular these 3 serious adverse events, which we think are important. And we recently studied some of this, which you can read more about there. So we've worked with Rick Bangs from this group, patient advocate, and other usability people to try to upgrade the public site. And we've been very grateful for his and other people's work. This is a beta site. It's currently up there as a beta site where we're trying different options of how many different, the homepage and having multiple search bars. Through Mr. Biden's Cancer Moonshot and other initiatives, we've been working with 18F, which is a government part. So we have a lot of people giving us a lot of advice, and we'll be launching a new look of the site in the next couple of months, I'd say. But one thing that we're doing now in the beta site is we're having a type ahead option. Here's an example of it. We're having the ability to filter right there. Let's see, the filter on the left, so it makes it a little bit easier for potential participants to use. So you can go around and play with the beta site, and we welcome any input. So again, users of ClinicalTrials.gov, you can use it to help identify trials of potential interest for an individual, track progress of a specific trial, identify all trials that are completed or ongoing. And a lot of people seem to use it to identify investigators or research centers of relevance to a specific condition. So even if you don't want to be in a trial, especially if you get a rare diagnosis or some very serious diagnosis, you might want to do that. So for those concerned, as I said, with human subjects protections, especially IRBs, I think this is very important. For those with medical conditions, I want to call your attention to our data are all fully downloadable, and we have an API which makes it, we think, easy for other groups to use it. And there are all sorts of clinical trial sites that in the depths are in fact using our data, which we think is wonderful. Obviously, this is a government resource. We're not in this to make money. The more people who use the data, the better. So this is based out of UCSF. This is breastcancertrials.org. And so they take our data and they do various things with it to customize it for their community, which we think is an excellent use. There are many disease groups that do this with our data. For those seeking study results, we do have linkages to PubMed, so if there are articles, we have results there. And you can also search, for example, if you want to find, you can search by a specific outcome. So the structured data lets you do things like search by a specific outcome measure. So you can say, you know, studies of this disorder with this outcome measure at 3 months, and you have a better chance of finding things that way. And many people use it for aggregate data and studies sort of the landscape of clinical trials, or using it for decision making. So I'll stop there and take any questions.
We have time for one or